This is Mrs. Alston for RAD 112. We're going to cover the lumbar spine, sacrum, coccyx, and SI joints. So as you know, the function of the vertebral column is to enclose and protect the spinal cord, which is located at mid-sagittal plane and posterior to the bony trunk. It extends from the base of the skull to the tailbone. The vertebral column is divided into 5 groups. You have the neck, which is known as the cervical, the upper back, which is known as the thoracic, the lower back, which is known as the lumbar, and the sacrum and coccyx. We will also cover the SI joints in this lecture. The vertebral characteristics are there are 7 cervical, and they look like mice. There are 12 thoracic, and they look more like giraffe with their spinous processes extending to the vertebral body below it. And then the 5 lumbar, which are the largest, and they resemble a moose. Now, the curvatures of the spine, remember that the lumbar and the cervical are compensatory or lordotic, and the thoracic and sacrum are primary or kyphotic. The compensatory has a concave curvature, and the primary have the convex curvature. Remember that the lumbar and the cervical curves are not going to be formed until the baby can hold their head up and walk. Looking at the diagram of the normal adult in the lateral profile, you'll see those compensatory and primary curvatures. They're both being lordotic or kyphotic. If you have extreme kyphosis or lordosis, that's when you have an exaggerated sway to the convexity or concavity of the curve. Looking at the spine from the AP projection, you have a usual vertical vertebral spine. The normal one is in the middle where you have a slight lateral curve, and this is usually towards the dominant hand. And then finally you have scoliosis, which is an exaggerated lateral curvature and can cause problems for the patient if not corrected. Here are some radiographs of a scoliotic patient with that surgery to help straighten up their spine. So the spine composition is made up of 2 main parts. You have the body and the arch, and remember that the arch is attached to the posterior lateral surface of the body at the pedicles, and that forms the vertebral foramen which the spinal cord traverses through. The majority of the structures are going to be in the vertebral arch, with the pedicles coming off the posterior lateral portion of the body. Then you have the transverse processes which jet out laterally posterior to the body. Between the transverse process and the spinous process, you have the superior and inferior articular processes, as well as the lamina, which is also known as the pars interticularis, and that acts as a bridge between the transverse process and the spinous process. Looking at your diagram from the lateral perspective, you can see the superior articular process and the inferior articular process, which sit above and below and just posterior to the transverse process. And then anterior to those articular processes are the vertebral notches, the superior and inferior, which make up the intervertebral foramen. Here's another diagram showing you the location of the superior and inferior vertebral notches, which when stacked upon each other, they will make the intervertebral foramen. Now, the joints of the foramen that we need to be interested in when we're doing the cervical, the thoracic, and the lumbar is going to be the intervertebral foramen and the zygapophyseal joints. This is where the majority of the movement occurs in your cervical as well as your lumbar vertebra, and this is where you can have degeneration or injuries occur which could cause pain to the patient. So the intervertebral disc space can sometimes protrude into the spinal canal, causing pain and numbness to the patient. So remember that you have discs that are held between the vertebra to help cushion when we are walking, standing, moving around. The 2 parts of the disc is going to be the annulus fibrosus, which is the outer, more fibrous portion, and then you have the nucleus pulposus. As I said, if that protrudes into the spinal canal, it could impinge on the spinal cord, causing the patient pain. Now, the joints of the vertebral column are going to be amphiarthrodal between the bodies of each vertebra, and they're cartilaginous. The apophyseal joints are going to be diarthrodial, and they are synovial joints. The main characteristics of the lumbar vertebra are their bodies are larger. L5 is going to be the largest one. Their transverse processes are going to be small, and their spinous processes are going to be large and blunt and sticking directly behind the posterior body. The lamina portion are large on the lumbar vertebra. Part of the lamina is the portion that lies between the two articular processes, and this is going to be called the pars interarticularis. Sometimes this pars interarticularis fails to unite the front and the back of the vertebra, which allows the front part of the vertebra to slip forward on the vertebral body below it. When this happens, it's called spondylolithiasis. Looking at the superior portion of the lumbar vertebra once again, you see that the superior articular processes sit at about a 45-degree angle between the body and the spinous process. This is going to be important when positioning for the oblique lumbar spine. For the AP projection of the lumbar spine, you should see the outline of the spinous process centered over the body. The transverse processes will be lateral to the body, and the pedicles are going to be on the lateral margin at the posterior portion of the body. Now this is just another diagram showing you the posterior view from the arch forward with the body being more transparent so that you can see the articulation of the pedicles, kind of like suction cups on a window, attaching the vertebral arch to the body, and then the transverse processes stick out laterally with the pars interarticularis, or part of the lamina, between the superior and inferior articular processes. So now I want you to stop the video and look in your textbook to identify the letters A through F. Once again, in the lateral projection, please stop the video and identify the anatomy labeled A through F. Now there is another common defect known as spina bifida, and this is most commonly seen in L5 area. This is when the two lamina fail to unite, leaving an opening where the spinous process is usually found. Sometimes infants are born with the spinal cord exposed outside of the body in extreme cases of spinal bifida. So here is an X-ray of an AP lumbar spine with that spina bifida. So as you're looking up the center of the spine from L5 all the way up to L1, you see the spinous processes are circled and they look like teardrops. At the very top, right below where the 12th ribs are coming off, you see that non-union of the spinous process, or a black line. That is spina bifida. This is another artist-enhanced image just showing you the structural components of the lumbar spine as it relates to an X-ray. Please note that the structures are not going to be demonstrated in the same way for the cervical, the thoracic, and the lumbar vertebra. Remember that in a lateral cervical spine, you see the zygapophyseal joints, but for your oblique L spine, you'll see the zygapophyseal joints. And with the lateral lumbar spine, you'll see the intervertebral foramen, but on the oblique cervical, you'll see the intervertebral foramen. So they're going to be different depending on which vertebral section you're in. This lateral lumbar spine, I want you to stop and look at this radiograph. We're best identifying the intervertebral foramen, the bodies, the intervertebral disc space, and the spinous process. So please take a moment to stop and look at your letters A through E. Now, when we talk about the Scotty dog was a way to help new people who were looking at radiographs identify the structures that are supposed to be best demonstrated on the oblique lumbar spine. So it is said that you can see what resembles a real-life Scotty dog within the structures of the lumbar spine. So looking at this, E would be the superior articular process on the vertebra, which makes up the ear of the dog. A is the transverse process, which makes up the nose of the dog. B is the pedicle, which makes up the eye of the dog. C is the pars articularis, which makes up the neck of the dog. And D is the inferior articular process, which makes up the leg of the dog. So you see that you have the inferior articular process of the superior vertebra articulating with the superior articular process of the inferior vertebra, which makes up your zygapophyseal joints. So this is just a radiograph outlining that Scotty dog along with the anatomy so that you can identify your structures. Once again, here is an outline of those structures forming that Scotty dog. I want you to take a moment and look at this radiograph and compare it to your textbook and label A through F. Make sure that you're aware of your lower spine landmarks, as we will be using these as we're palpating our patient to put them in the correct position for the lumbar series. We'll now go into the lumbar spine positioning. For the routine, we're going to have the AP, both obliques, the RPO and the LPO, the left lateral, and the L5-S1 spot. If you are performing trauma, it's going to be the AP, the cross-table lateral, the cross-table lateral L5-S1, and trauma obliques. You can also have a two-view lumbar spine that could be ordered, and that is the AP, the lateral, and the L5-S1 spot. For the AP lumbar, we're going to have the patient supine on the table using the table bucky with a 40-inch SID perpendicular beam. We're going to have it centered to the iliac crest and mid-sagittal plane, and you want to keep your collimation open head to toe for the 14x17, and then close it up side to side to have about 1 inch on the lateral side of the SI joints at the pelvis, and from T12 down to about the upper portion of the sacrum. You want to ensure that there is no rotation on your patient's body by seeing the pedicles on the lateral border symmetrically of the posterior aspect of the body, as well as the spinous processes in the center. Note that for males, we're still going to shield at the gonadal area and put your marker at the upper or bottom corner anatomically correct. It's going to be done on suspended respiration. I typically use expiration. Now, when you're looking at the female, you see how the curvature of a female is a little bit more lordotic than most males are. So you want to ensure that you are flexing those legs and putting a sponge up underneath your patient, whether they are male or female, to ensure that the spine stays parallel to the image receptor, which is going to allow the intervertebral disc space to remain open. So it's still going to be the same concept. 40-inch SID, perpendicular beam, iliac crest and mid-sagittal plane, flex up the legs, and this time we will protect the patient's mammary glands instead of the gonadal region. Here is an inset picture of a prone patient if you have to perform it prone instead of supine. It's still going to be an iliac crest and mid-sagittal plane. Here's the radiograph for the AP lumbar spine. You want to see from T12 down to the superior portion of the sacrum. You should see no rotation. The ribs should be symmetrical. The transverse processes should be symmetrical. You should be able to see both SI joints on either side. You should see the pedicles, equal distance on the lateral posterior body. You should see the spinous processes looking as teardrops in the center of the body. For your oblique lumbar spine, you're going to perform these in the posterior oblique, and that's going to allow you to see the downsided zygapophyseal joints. We're going to roll our patient up into a 45-degree obliquity. So what you're going to do is you're going to have the patient take their arm and stretch it across their chest, bend up the same sided leg, and then you will take their hip and their shoulder and roll them into a 45-degree oblique. Then you can use the 45-degree sponge up underneath them to help hold them in place. Place the arm and the leg straight down by their side. It's going to be a perpendicular beam, 40-inch SID, 1 inch to 2 inches above the iliac crest and 2 inches medial from the upsided ASIS. So what I mean by that is the larger picture has the patient in an RPO. They are coming 2 inches in towards mid-sagittal plane from the left ASIS. You also see the inset of the anterior obliques, which is actually going to show the upsided zygapophyseal joints. So if you're doing an LAO, that will show the right-sided zygapophyseal joints. Here's an image of our oblique L spines. Remember, the posterior obliques will show the downsided zygapophyseal joints, and the anterior obliques will show the upsided zygapophyseal joints. So whichever way the Scotty dog is walking, or whichever way the eye is facing towards that crest on a posterior oblique, that's the way the patient was rolled. So for this one, the patient is in an RPO, and we're seeing the right zygapophyseal joints. Now, it's important to know if the patient was under or over rotated when you're looking at your obliques to determine if you have them positioned correctly. We're going to check that with the Scotty dog's eye or the pedicle. If the pedicle is too far anterior on the vertebral body, or looking more like the pedicle is still on the lateral margin of the body as it would be for an AP, the patient was not oblique enough. If the pedicle is too far behind the center of the vertebral body, then the patient is going closer to a lateral and the patient was oblique too much. Make sure that when you're looking at your oblique lumbar spine, you're looking at around the level of L3 because that one is going to look the most open with a 45-degree rotation on the patient. Now note that Bontrager says that if you are looking specifically for lumbar number 1 or 2, you want a 50-degree rotation on the patient's body. If you're looking more for L4, L5, you only want a 30-degree rotation. But all of your clinical sites will do a 45-degree, and that should be your answer unless they are specifically giving you other indications to let you know that you're looking at other lumbar spine. I'm going to go on to the lateral lumbar now. So if you have a patient that has scoliosis, the patient should be placed in whichever lateral position places the sag or convexity of the spine down to better open those intervertebral spaces so the radiologist can see them better. If not, we're going to place the patient in a true left lateral position. You're going to have them flex their legs up and place a sponge in between to make them more comfortable if necessary. Make sure to double the pillow so the cervical spine is supported and put their arms up by their head like they're sleeping. Now, both of these images are showing that there are sponges underneath the waist portion of the patient's back, and that's to ensure that the lumbar spine remains parallel and open to the image receptor. So for the image that is at the top, that is a male patient, you see that with the support, the spine is now parallel to the image receptor. Thus, we can use a perpendicular beam and not place an ankle on the two. So it's still going to be a 40-inch SID at the iliac crest and mid-coronal plane. You want to collimate anterior to posterior so not to get too much soft tissue of the abdomen, but keep your head and toe open to the 14/17. Make sure that you use your left marker as this is a left lateral, and we always mark the side for the lateral that's closest to the IR. You can put that in the front or the back of the patient, although it usually shows up better when it is placed anteriorly versus posteriorly. This is going to be done on suspended respiration, and make sure that you shield the patient appropriately. The image at the bottom is a female, and even though she has a sponge up underneath her waist, her hips are still wider than her waist is, causing her back not to be parallel to the image receptor. If this is the case, you can put a 5 to 8 degree caudal angle on the tube and still center at mid-coronal plane and iliac crest, and make sure that you're collimating accordingly. This is going to be the image of your lateral lumbar. You're best demonstrating the intervertebral foramen, the bodies in profile, the intervertebral disc space, and the spinous processes. You should see no sag or no rotation on your patient. We're now going to move on to the L5-S1 lateral with a support underneath the waist. So for the lateral L5-S1, the patient's still going to be in that left lateral position, ensure that they are in a true lateral. We are going to center 1.5 inches inferior from the iliac crest and 2 inches posterior from the ASAS. So when you're doing your oblique lumbar, it's between 1 and 2 inches. So I go 1.5 inches above the iliac crest and 2 inches medial from the upsided ASIS. Then when I do my L5-S1, I already know the central ray location because I go 1.5 inches below the iliac crest and 2 inches posterior. So the oblique is 1.5 up and 2 in, and the L5-S1 is 1.5 down and 2 back. When you're doing this, you can collimate down to about a 4x4 just to make sure that you're getting that L5-S1 area. That's all we're interested in seeing is that joint space there. You want to make sure that that joint space is open, so you may or may not need to have a 5 to 8 degree caudal angle. Once again, look at your spine to determine if you need that to keep that space open. This one is with support. This next image here does not have the support. And if you look at the intervertebral foramen, you see that there are two problems here. First of all, I see the pedicles are not superimposed, so that there was a sag on the patient's back. I can tell that because I do not see the blocks in the body. It should be one block or one marshmallow without being able to see both sides or both rims of the body. And I should see the pedicles stacked directly on top of each other where I cannot tell one from the other. So that is sag. Rotation is when I am showing the zygapophyseal joints in the intervertebral foramen. So if you look at the area between L4 and L5, you can see the superior articular processes within the intervertebral foramen, which means that this patient not only has a sag on their back, but they also have rotation on their hips. So ensure that you are properly positioning your patient so you do not have to repeat. All right, we're now into the sacrum and coccyx anatomy. So the sacrum is convex curved. It has superior articular processes which will articulate with the inferior articular processes of L5. It has the wing or the ala, just like the pelvis does. It has a sacral promontory, which is the superior portion there, just below where the superior articular processes are. It has the body, which is the first segment, and it sits most anterior in the lateral. It has 4 pairs of sacral foramen, which allow the blood vessels and the nerves to feed the lower legs. And then at the bottom, you have the apex. Looking at it from the lateral perspective, you can see the superior articular processes there. In between that area, you have the sacral canal. You can see now the base and the body is going to be the most superior with the sacral promontory the most anterior. Now the part that articulates with the ilium on the pelvis is going to be called the auricle, and that surface makes up the sacroiliac joint or SI joint. Now that we're in the lateral view, you can see the median sacral crest, and they are fused spinous processes at birth. Just below that, you see the sacral horn or cornu, and then you also have a horn or cornu of the coccyx. Here is a posterior diagram of the sacrum. Please stop the video and look in your textbook to identify letters A through E. Here's the coccyx. The coccyx is about the size of a postage stamp. You'll see that the widest part is going to be at the base. The base also has 2 transverse processes coming off on the lateral aspect. It also has superior articular processes to articulate with the distal end of the sacrum. It can be 3 to 5 segments that are fused together. The apex is going to be the lower portion, and it points in towards the pubis, and the base is the broad superior portion. So here's just that comparison of a postage stamp to the actual size of a coccyx. As I said earlier, the apex points to the pubis. The more pronounced are going to be in the males, as we do not want it to be pronounced greatly in the female because it would obstruct the birth canal. A blow to the coccyx could rupture the rectum, which could be a serious injury to a patient. Okay, we're going to go on to the apiaxial sacrum. So for both the sacrum and the coccyx, you want to ask the patient to try to void or defecate because you don't want to have anything in their bladder or any fecal material superimposing those structures, although it is very difficult to get somebody to use the restroom on command. So for our sacrum positioning, we have the apiaxial and the lateral. The apiaxial is going to have a CR angle of 15 degrees and it's going to be cephalic. So in showing that, it's going to give us a non-foreshortened AP projection of the sacrum with the SI joints and L5-S1 junction open. Our central ray, as I said, is going to be 15 degrees cephalic. We are going to be entering 2 inches above the symphysis pubis and mid-sagittal plane with no rotation on your patient. You probably can collimate down to an 8 by 10 and place your marker towards the bottom corner since that is the smaller or the more narrow portion of your sacrum. Now the entire sacrum should clear the symphysis pubis with that angle on it. However, the coccyx may still be superimposed. You should be able to see the sacral foramen a little bit more open because that angle is going to help remove the convexity or the kyphotic curve on the sacrum. So the lateral sacrum and coccyx are done together. So we do them together because they are joined in one, and it's easier to get the lateral sacrum and coccyx than it is to get a lateral sacrum and a lateral coccyx. So anytime you have the requisition, you're actually going to do the apiaxial sacrum, the apiaxial coccyx, and then 1 lateral sacrum and coccyx. So 3 projections total for this exam. So for the lateral, you're going to make sure that the patient is in a true left lateral position, and then you're going to center about 3 to 4 inches posterior from the ASIS. Ensure that you have from L5 down through the tip of the coccyx. So here's an image showing you the lateral sacrum and coccyx. You see the sacrum in profile, the body of L5 is in profile, the coccyx is in profile. You see that the pelvic bones are superimposed on top of each other. You can notice the median sacral crest and the sacral cornu as well as the coccyx there. The coccyx position is going to be the AP and the lateral, and then trauma will be a PA with a 10-degree cephalic angle and a cross-table lateral. So just like for the AP sacrum, the patient is going to be supine. You can flex the knees for both of these, but we're going to change the angle to 10 degrees caudal. The center ray is still going to enter 2 inches superior to the symphysis pubis and mid-sagittal plane. So the way I remember which angle and how steep the angle is sacrum cephalic. Sacrum cephalic. So they sound like a soft C for both of them. So the sacrum has the cephalic angle. Coccyx has the caudal angle, so it's a hard C. Coccyx, caudal. Now, how do you remember the degree? The sacrum is a larger bone, so it'll be 15 degree cephalic angle. The coccyx is a smaller bone, so it's a 10 degree caudal angle. Make sure that you minimize your collimation down to about a 4x4 because remember the coccyx is only the size of a postage stamp and we do not want to expose a patient unnecessarily around the gonadal area. So for the lateral sacrum coccyx, once again, the patient's going to be in a true lateral position and you're going to position 3 to 4 inches posterior from the ASIS. There's only one lateral that you do. All right, we're moving on to the SI joints. This is the last portion of this lecture. So for the AP axial SI joints, the patient's going to be supine as they have them with their legs flexed. We're going to use a 30 to 35 degree cephalic angle, with the females requiring more of an angle because the SI joints are usually more curved because of the sacrum. Our center ray is going to be 2 inches below the ASIS and mid-sagittal plane. You want to suspend your respiration, and you're best going to demonstrate the SI joints and open L5-S1 joint space. So here's a radiograph of the AP axial SI joints. You should see the sacrum in the center of the pelvis. You should also note the spinous processes are going to be in the center on L4, L5. You should see the SI joints partially open and have about 1 inch on either side of the ilium included on the radiograph. You do not need to see the entire sacrum because this is just for the SI joints. That 30 to 35 degree cephalic angle helps to open up or elongate the SI joints for a better view for the radiologist. We're going to do both posterior obliques. The patient is going to be rotated by 25 to 30 degrees because that's how much the auricle lies. It lies in a 25 to 30 degree obliquity. So roll your patient up by about 25 to 30 degrees. The CR is going to be 1 inch medial to the upsided ASIS. Now, Bontrager shows you to do them unilateral, but most of our clinical sites prefer the bilateral, so they want to see the upsided right and the downsided left and vice versa. But make sure that you're following your protocol. On these, you're going to not follow the post is close rule, so you're actually looking at the upsided SI joints because when you roll the patient into a 25 to 30 degree obliquity, that's actually going to make the beam perpendicular through that joint space. So here's a radiograph looking at the oblique SI joints. So the image on the left-hand side, the patient is going to be in an LPO because you see that the right wing is lifted and the white arrows are showing you the open SI joint. So in an LPO, we're actually looking at the right-sided SI joint. And then vice versa on the image on the left wing is now going to be lifted so the patient is in an RPO, but the yellow circle is indicating that the left SI joint is now open. So that concludes the final lecture of your vertebral column. Thank you.